So for our last talk before the lunch break, we're going to hear about a project that leverages EHR data and other VA clinical data, hear from a unique database of suicide surveillance. For this, we'll be hearing from Dr. Alejandro Szmulewicz, who is a psychiatrist, epidemiologist, trained in Argentina and in the US. He worked as chief psychiatry resident at a psychiatric emergencies hospital in Argentina before completing his MPH and his PhD at HSPH. As a member of CAUSALab, he studies the causes, treatments, and outcomes of psychotic disorders, PTSD, opioid use disorders, and major depressive disorders, all using causal inference methods. And so please join me in welcoming Dr. Szmulewicz.
Okay. Hi, everyone. Thanks for having me. Okay, to get started, the same disclosures as everybody before. What I'm going to do here is briefly introduce the topic, do a brief background on prior attempts to answer this research question. The research question is, does lithium reduce suicide or not? On top of that, what I will do is describe two obstacles that researchers who try to answer this research question have faced in the past. And also in doing so, I will describe some of the ways in which we try to overcome those obstacles. To begin with, I will be very brief. I'm sure you are all familiar with this. Suicide is a major public health concern. In the US, it claims 50,000 deaths annually, and since the year 2000, it has been shown an increase every year in its incidence. Mood disorders separately are conditions that entail a heightened risk of suicide. If we look at bipolar disorders, we see a 30 times increase in the risk of suicide, and if we look at major depression, a 10 times increase in the risk of suicide as compared to the general population. This creates a good opportunity to develop targeted prevention efforts. This is a population at high risk of suicide and at which we can find intervention that might reduce this risk. A brief introduction on how we treat these disorders. Major depression disorders are characterized by depressive episodes, and the first line of treatment are SSRI antidepressants. The thing is that when these treatments don't work, psychiatrists often combine these antidepressants with other agents, such as lithium. Bipolar disorders, conversely, are characterized by depressive episodes plus manic or hypomanic episodes. Psychiatrists typically treat these conditions with mood stabilizers, such as lithium. There is a need to understand what is the comparative effectiveness of different agents, not only to treat these disorders, but also to prevent suicides in this high-risk population. Of course, lithium, because it's used in both conditions, is a very good candidate preventative agent. What I will say is that the idea that lithium prevents suicide has been running around since the 70s. Someone made the observation that in randomized trials that were originally designed to look at whether lithium works or not in mood disorders, that is, to treat mood disorders, someone found that there were no suicides in patients that were assigned to the lithium arm. That led to a group of investigators that meta-analyzed the randomized trials. Again, these are randomized trials designed not to look at suicide, but rather to look at whether lithium works or not in these patients with these conditions. And they found a very strong protective effect of lithium against suicides. This finding later came into the clinical guidelines, which now recommend that we should use lithium to prevent suicide with a level of recommendation A. One thing about this finding is that this meta-analysis was based on only 4 randomized trials that you can see here, and you can see 6 events in patients that were assigned to lithium and no events in patients that were, 6 events in patients that were assigned to placebo and no events in patients that were assigned to lithium. The fact that there are so few events leading the results can be seen by the fact that since then, 2 other research groups have tried to replicate the results with slightly different analytical choices, and the results are very unstable and very, of course, imprecise, as you can see from the confidence interval. Because of this, since then, researchers have been trying to do randomized trials, specifically looking at whether lithium prevents suicide or not. The problem is that suicide is such a rare event that it cannot be the primary outcome of these trials. So instead of that, what has been happening is that the primary outcome is something that's called suicidality or suicidal acts. It's a composite outcome that includes suicides, but also suicide attempts, hospitalizations to prevent suicide, suicidal ideation, this composite outcome. In almost all of these randomized trials that have been published since then, with a very similar design, what we can see is that there is no evidence for an effect of lithium in preventing suicidality. The largest of these randomized trials was published a couple of years ago, the CSP 590 trial that was conducted at the VA, randomized more than 500 patients to lithium or placebo. The primary outcome, again, as in all of these trials, was this composite outcome of suicidality, showed that there was no effect of lithium in preventing suicidality. To summarize the evidence on this research question, does lithium prevent suicide, is that randomized trials, they offer unbiased estimates, but their weakness is first that most of these trials had a huge degree of non-adherence. Between 50 and 80% of patients showed non-adherence to our treatment strategy. Of course, this is a very complex clinical population. These are mood disorder patients at high risk of suicide. The other weakness is that this study only allows the randomized trials with a short follow-up period. You can only look at suicidality. Observational studies, they benefit from a larger sample size and allow you to study suicide as the primary outcome, but the problem is that typical observational data don't have information on the suicide risk factors that is needed to adjust for confounding by indication in this case. So that summarizes the 2 obstacles that I mentioned. The first obstacle in randomized trials to interpret the evidence that comes from trials is the high degree of non-adherence. To try to sort this obstacle, a few words on a collaboration within the VA-CAUSAL and the VA-CSP. The CSP is the division of the VA that's responsible for the planning and conducting of large multi-center randomized trials. It's a huge research infrastructure that includes statistical, epidemiological, and pharmacy centers. And we developed a collaboration with the CSP in order to reanalyze the data from the CSP 590 trial, this huge trial that tried to answer this research question, but in order to complement the results from the trial with a per-protocol analysis. That is, we wanted to answer what would have been the results from the trial if patients had adhered to their treatment strategy. For example, we wanted to know what would have been the effect if lithium was assigned at baseline and continued unless the patient developed serious side effects or clinical concerns or drug-drug interactions. To do this, we reanalyzed the data from the CSP 590 trial, first censoring individuals when we had evidence that they had been non-adherent to their treatment strategies. What you can see here is how that censoring affected the estimates. Essentially, what you see is that in the left, we have the results from the intention to treat analysis that showed that lithium was slightly harmful in suicidality. After censoring at non-adherence, this is the only thing that we do, that is, we stop considering events that happen after non-adherence. We see that the risk in the lithium arm goes down, making the 2 cumulative incidence curves overlapping with each other. The reason for this is that many events occur in lithium patients after they discontinue their treatment. It has been widely documented that the stopping of lithium treatment is associated with a higher risk of suicidality, and this is what we are essentially seeing in these curves. Of course, because we restrict the data to patients who adhere to the protocol, we have broken randomization. And what we observe is that now samples are growing differently as the trial unfolds. Specifically, we are seeing that patients in the lithium arm, if they had bipolar disorder, were more likely to stay. These are odds ratios for non-adherence. And if patients had suicidal thoughts, they were more likely to be non-adherent to the placebo arm. This is expected because lithium is an intervention that's very hard to conceal. Patients, of course, were aware of the treatment that they were receiving. Lithium has a very characteristic pattern of side effects. After we adjusted for the confounding that we created by restricting the sample to individuals who adhered, as expected, we see a further drop in the risk of lithium. And the finding was that there's a sign for a protective effect of lithium against suicidality, but the confidence intervals are very wide to make a firm decision. And this is because the sample size was not huge. But the main point is that the confidence interval includes the limits for the alternative hypothesis that was proposed by the data monitoring committee. The other obstacle in this research question is whether the randomized trials are using suicidality as their main outcome. Is that a valid surrogate outcome for suicide? Stated differently, is it possible that the trial findings are negative because we are using suicidality instead of suicide as the primary outcome? As you can see here, there are many differences between suicide and suicidality. They have different epidemiology, frequency, method, genetics. There are very different conditions. A reasonable step forward would be to combine the strengths from observational data and randomized data to try to answer this research question. In the past, observational studies have been used to study whether lithium prevents suicides or not. The problem is that the confounding by indication is highly likely in observational databases because we don't have data about suicide risk factors in observational data. This is further suggested by looking at the effect estimates. Before the clinical guidelines were published, there were strong protective effects of lithium, and this was reflected by the fact that psychiatrists were avoiding using lithium in high-risk patients because lithium can be very harmful or very lethal in overdose. So it made sense that psychiatrists were avoiding this treatment in patients at high risk. After the guidelines are published, we start seeing a higher risk of suicide in lithium in observational data because lithium now is shifted and being used in patients at high risk of suicide. So what we propose to do is to use the results from the randomized trial, the CSP590, as a benchmark. And this makes sense because we can now ask the same causal question in the same population and in the same healthcare system because we can replicate the analysis in the VA observational database. This is what we did. This is a summary of the protocol of the CSP590 trial, the eligibility criteria, the treatment strategies, and all the characteristics of this trial. When we try to emulate this trial in the observational database, we run into two challenges. The first one is that it's very hard to emulate the randomization because with the observational data, EHR data typically don't have information on suicide risk factors. To overcome this issue, we complemented the EHR data with patients' record flags. Since 2010, the VA, for clinical reasons, they implemented a flag in patients in the EHR of patients at high risk of suicide. This was intended for a clinical reason, so that the clinical contacts and the treatment is enhanced in these patients, but it has the unintended effect of helping observational research. We now can get a glance of which patients received lithium because they were at a high risk of suicide. The VA also conducts annual screenings every year on many risk factors for suicide. We apply the eligibility criteria to the observational database, and what we can see here is that those eligible patients who initiated lithium and those who don't, they were very different in variables that capture suicide risk factors. And the important thing is that these variables are typically unavailable in most observational databases. The second difficulty is that the outcomes were adjudicated by an endpoints committee in the CSP 590 trial. This is very difficult to replicate, but it's super important because the ICD definition of suicide attempt doesn't have great characteristics. To try to emulate that adjudication of the outcomes in the CSP 590 trial, again, we complemented the EHR data with the VA SPAN database. This is a centralized report in which all suicide attempts are validated by a clinical expert since 2010. All reports are centralized and are adjudicated using standardized classification. To put it all together, these are the preliminary results of our benchmarking. And in the first row, we can see the intention to treat results from the CSP 590 trial. In the second row, the results if we emulate everything in the observational data, but we don't adjust for suicide risk factors. And in the last line, if we adjust also for suicide risk factors for the variables that I showed you before. Benchmarking is the first step. What we want to do next, now that our confidence is high in that we have sufficient data to emulate this target trial, is to extend the analysis to study suicides instead of suicide attempts over longer follow-up periods and in clinically relevant subgroups. So to conclude, for the first obstacle, we developed a synergy between VA-CAUSAL and the CSP to lead the per-protocol analysis. And for the second obstacle, we complemented the electronic health records with suicide surveillance, screening, and patients' record flags data to try to benchmark the CSP 590 trial. Thank you.